Bismillahirrahmanirrahim. We will start with the verse of Holy Quran. Indeed, what is come to you, indeed, what is come will be better for you than what has gone by. Today, I will be presenting the topic of minerals, mainly calcium, phosphorus, sodium, potassium. I am Dr. Taimia Ayub, and I am presenting this topic under the kind supervision of Professor Dr. Saira Afzal, Institute of Public Health, Lahore. So, this is the outline of today's lecture. We will start with the public health importance of minerals, and we will cover four minerals of calcium, phosphorus, sodium, and potassium. These are the learning objectives of today's lecture. So, what are minerals and why are they important in with public health perspective? Minerals are essential micronutrients required in small amounts. Imbalances contribute significantly to osteoporosis, hypertension, cardiovascular diseases, renal disorders. Public health relevance is that as our diets are transitioning and the consumption of processed food is increasing, especially there is focused on salt heavy diets and low dairy and fruit and vegetable intake is happening. So in this context we will describe these minerals and how what are their long term consequences. So, first of all, we will classify minerals into macronutrients and trace minerals. So, macro minerals are those which are required in more than 100 milligram per day. These are mainly calcium, phosphorus, sodium, and potassium. And trace minerals are like iron, zinc, iodine, selenium, etc. So, we will start with calcium. Calcium is the most abundant mineral in human body. 99% of total body calcium is stored in the bones and teeth as hydroxyapatite. About 1% is present in blood or extracellular fluid and intracellular compartment. This 1% is metabolically active and critical for survival. So this is the diagram which is showing the distribution of calcium in our body. As you can see, most of the it is present in the bone about 99%, then about 1% is present in the soft tissues, and even among that 1%, a small percentage is present in the extracellular fluid, and how further it is divided. So each component is very important. So, key physiological role which calcium plays is that it helps in bone and teeth mineralization, muscle contraction, nerve impulse transmission, blood coagulation, enzyme and hormone signaling. So, normal calcium level in the body in the adult are total serum calcium 8.6 to 10.2 milligram per deciliter, ionized free calcium 4.5 to 5.6 milligram per deciliter. Ionized calcium is a biologically active fraction and is more clinically meaningful, especially in critically ill patient. Form of calcium in blood, ionized, again free, and then we have protein bound, mainly bounded with albumin, and then complexed. So why how regulation of blood calcium homeostasis occur? Blood calcium is tightly regulated by parathyroid hormone, increases calcium level, vitamin D, calcitriol level, which also increases intestinal absorption. Then we have calcitonin, reduces bone resorption, and public health relevance, vitamin D deficiency, common in South Asia, disrupts calcium homeostasis. Low dietary calcium plus low vitamin D leads to secondary parahyperthyroidism and bone loss. So, hypocalcemia or low serum calcium causes our vitamin D deficiency, poor dietary intake, malabsorption, chronic kidney disease manifestation. It results in muscle cramp, tetany, seizures, bone demineralization. And if the conditions are hypermineralization or high serum calcium level, it results in hyperparathyroidism, um Excess supplementation public and the importance from public health perspective is that it is less common but important in supplementation program. So these are some of the symptoms of hypocalcemia. Dry skin, tooth decay, hair loss, muscle cramps. And then we have calcium requirements. Recommended daily calcium intake life course during the life course. In adults for 19 to 50 years of age, it is roughly 1000 milligram per day. More than 51 years of age, for men, it is 1000 milligram per day, and for women, it is 1200 milligram per day. Adolescence is the critical window for peak bone mass. If there is inadequate intake, it can lead to increased lifetime risk of osteoporosis and fractures. Higher requirement in older women due to post menopausal bone loss. Then we have requirements. Calcium requirements during pregnancy. Pregnant women from 90 to 50 years of age, it is 1000 milligram per day as explained. In pregnant adolescent, it is more 1300 milligram per day. And WHO recommends calcium supplementation of 1.5 to 2 gram per day in populations with low dietary intake to reduce preeclampsia risk. Similarly, lactating women also are required 1000 milligram per day. And there is important concept that calcium loss in breast milk is not primarily compensated by higher intake but by temporary maternal bone resorption. Bone mass typically recovers after weaning off. So these are 10 calcium rich foods for which are which should be encouraged in pregnancy, like milk, spinach, seafood, lentils, almond, oranges, dry fruits, etc. So dietary sources are present in high bioavailability in is in milk, yogurt, cheese, moderate amount small fish with bones and fortified food. Then we have leafy greens with high oxalate and phytates level. Absorption is enhanced by vitamin D and inhibited by oxalates and the excessive sodium. Calcium rich vitamins are, yes, these are some of the calcium rich vitamins. So, what the global situation is that inadequate calcium intake is a population wide nutritional risk factor that contributes to disease primarily through skeletal fragility, maternal complication, disability, and loss of functional capacity. Unlike acute deficiencies, calcium related harm accumulates silently over the course, making it a major hidden burden in public health. For osteoporosis and fragility fractures, globally, osteoporosis affects more than 200 million people worldwide. It is estimated that 1 in 3 women and 1 in 5 men over 50 years will experience an osteoporotic fracture. Hip fractures are the most serious, 20 to 30% mortality within 1 year, significantly long term disability among survivors. And a disability burden in tallies is that fragility fractures are a major cause of years lived with disability and loss of independence in older adults. Global maternal health burden related to low calcium intake. Hypertensive disorders of pregnancy, including preeclampsia, affects 5 to 10% of pregnancies globally. Strongest seen in low calcium intake population. Preeclampsia is the leading cause of maternal mortality, preterm birth, low birth weight, and perinatal mortality. So in Pakistan, contributing factors for low calcium level in diet are low dairy consumption due to cost, dietary pattern dominated by cereals, limited food fortification, cultural misconception about milk intake in adults. This leads to high prevalence of osteopenia, osteoporosis, especially among women, fracture risk increase due to aging population, urban sedentary lifestyle, vitamin D deficiency coexisting with low calcium intake. So this is the number of osteoporosis patients in Pakistan, about 9.91 million, and among them 7.1 million are women and 2.7 are men. So now we come to phosphorus. Phosphorus is the second most abundant mineral in the human body after calcium. It is indispensable for energy, metabolism, skeletal integrity, and cellular functions. From a public health perspective, phosphorus is unique because deficiency is uncommon at public health level. Excess intake is increasingly prevalent, especially due to ultra processed food. Disease burden is therefore driven mainly by overconsumption and dysregulation, not deficiency. 85% of total body's phosphorus is stored in bones and teeth as calcium phosphate. 14% is found in soft tissues and muscle. 1% is present in extracellular fluid and blood. So the role which phosphorus plays is the structural component of bones and teeth, energy production by ATP and ATP, cell membrane are made up of phospholipids, and then maintain acid-base balance and regulation of enzymatic reactions. Normal serum phosphate level are about 2.5 to 4.5 milligram per deciliter. In children, slightly higher due to growth demands. Regulated by kidneys, which are the primary regulator, parathyroid hormone, vitamin D, fibroblast growth factor. And disruption of phosphate regulation is common in chronic kidney disease, metabolic disorders, and aging population. Recommended intake of phosphorus is recommended about 700 milligram per day. Sources are meat, poultry, dairy, processed food, phosphate additives, and these are the main source of due to which there is high level of phosphate in our bodies. Global burden of phosphorus related disease, excess phosphorus intake. Average phosphorus intake in many countries exceeds physiological needs. Major contributing contributor phosphate additives in processed meat, soft drinks, packaged and fast foods. Additive phosphates have nearly 100% bioavailability, unlike natural food phosphorus. Chronic kidney disease and phosphorus. CKD affects 10% of the global population. In CKD, phosphorus excretion is impaired, hyperphosphatemia is common and develops. Elevated serum phosphate is associated with increased cardiovascular mortality, vascular and valvular calcification, faster CKD progression, and it is a major modifiable dietary risk factor in CKD populations. Also, it can lead to cardiovascular disease, associated with arterial stiffness, coronary artery calcification, increased all-cause mortality. And then we have bone health and calcium phosphorus imbalance. Optimal health depends on a balanced calcium phosphorus ratio. High phosphorus intake with low calcium intake results in secondary hyperparathyroidism, increased bone resorption, reduced bone mineral density. As mentioned previously, that in Pakistan, due to increased consumption of sugary beverages and processed and packaged food, we have a high phosphorus intake, and also it is associated with poor labeling awareness, no regulation of phosphate additives, and interaction of existing health burden, rising prevalence of hypertension, diabetes, chronic kidney disease. So it is growing but largely unrecognized phosphorus related disease burden. So these previous two minerals were related to bone health and mainly bone and their maintenance. And now we have two minerals which are sodium and potassium, and they are mainly related to hypertension and blood pressure in our body. So let's see how they work. Sodium is an essential macromineral and electrolyte required for normal cellular and physiological function. From a public health perspective, sodium is one of the most important dietary risk factor globally, not because of deficiency but due to chronic excess intake. Excess sodium consumption is a leading modifiable risk and cause of hypertension, cardiovascular disease, stroke, and premature mortality worldwide. So, what physiological role sodium plays in the human body? It is the major extracellular cation. It regulates fluid and electrolyte balance, blood volume and blood pressure, nerve impulse transmission, muscle contraction, and it works closely with potassium via the sodium potassium pump. 90 to 95% of the body sodium is in extracellular fluid. Small intracellular fracture is tightly regulated. Even small, sustained increases in sodium intake leads to population-wide rises in blood pressure. So normal reference range for serum sodium is 135 to 145 millimole per liter. It is regulated by kidneys. Hormone control is through aldosterone, antidiuretic hormone, and renin-angiotensin-aldosterone system. Recommended daily intake of sodium in adults. WHO recommends less than 2 gram sodium per day, which is equivalent to 5 gram of salt per day. So this is the recommendation from WHO. In children, lower age specific limits adjusted for energy needs. In pregnancy and lactation, there is no increased physiological need, and same are the needs as in normal adults. Most population consumes 2 to 3 times the recommended intake of sodium. So these are the dietary sources of sodium. Major sources in population level which are more dangerous are processed and packaged food about 70 to 80%, in restaurants and fast foods, pickles, sauces, condiments, bread and bakery products. These are one of the major sources of increased level of sodium in population. Then we have minor sources like naturally occurring sodium in food, salt added during cooking or at the table. So, reducing discretionary salt alone is insufficient. Food system level change is required. So, in the for the sodium and its changes, what is being emphasized here that system level changes at government and management level that there should be done. It is very good to decrease salt in our normal regular food also, but we are consuming so many things or so many food which are being processed or packaged, and the intake of sodium in those food is beyond our control. So on the right side there is a figure in which there are some high sodium foods. Harmful effects of excess sodium intake, hypernatremic diet. It mainly affects on heart and renal effects, leads to hypertension, strong linear association, stroke, ischemic and hemorrhagic both, and then ischemic heart disease and chronic kidney disease progresses more. And other health effects are left ventricular hypertrophy, increased risk of gastric cancer, calcium loss in urine, leading to potential bone health impact. And if are taking low sodium in our diet, hyponatremia, it can cause excessive water due to excessive water intake, diuretics, severe diarrhea, vomiting, certain chronic illnesses. It results in nausea, headache, confusion, seizures, and but it is not that much of a population level problem. And these are some of the symptoms which are explained in the figure on the right side, like muscle cramp, lethargy, nausea, seizures, confusion or headache. So now we come to global burden of disease attributable to sodium. High sodium intake is mainly responsible for millions of deaths annually, a substantial proportion of stroke deaths and cardiovascular mortality. Elevated blood pressure is among the top global risk factor for dialysis. Sodium reduction is classified as best by public health intervention by WHO. Average global intake is 4 to 5 gram sodium per day. WHO targets 30% relative reduction in population salt intake. So now we come to Pakistan and burden of sodium related disease. Average intake is well above WHO recommendation. High use of added salts in the cooking, pickles, chutneys, processed snacks, and bakery items. Hypertension prevalence is present in about more than 30% of the adults. They are not aware of their status and treatment options and control rate. Stroke and heart disease among leading cause of mortality. Excess sodium intake is a major upstream driver of this burden. We will discuss more about the global situation and prevalence of hypertension with in context of potassium also. So now we will cover the potassium portion. Potassium is an essential macro mineral and electrolyte that plays a critical role in cardiovascular, neuromuscular, and renal functions. From a public health perspective, potassium is important because low intake is highly prevalent worldwide, counterbalances harmful effects of excess sodium. Adequate intake significantly reduces hypertension and cardiovascular disease risk. And this is the role of potassium in the normal human body. It is a major intracellular cation, maintains intracellular fluid balance, cell membrane potential. It is essential for nerve impulse transmission, skeleton and cardiac muscle contraction, and normal heart rhythm. Regulates blood pressure by promoting sodium excretion, natriuresis, and reducing vascular resistance. So normal level of potassium, serum potassium is 3.5 to 5.0 millimole per liter. It is regulated by kidneys, which are the primary regulator, and under the influence of hormones, aldosterone, insulin, and acid-base balance. So WHO recommends more than or equal to 3,500 milligram per day for adults. In children, lower age-specific requirements based on energy intake, pregnancy, and lactation. There is only slightly increased needs. Emphasize on dietary sources rather than supplementation. Most populations consume far below recommended potassium level, which is in contrast with the sodium. So, dietary sources of potassium, major natural sources are fruits, bananas, oranges, mangoes, vegetables, spinach, potatoes, tomatoes, legumes and beans, nuts and seeds, and whole grains. Potassium intake reflects fruit and vegetable consumption. Low intake indicates poor overall diet quality. And on the right side, there are some food which have higher level of potassium in them: watermelon, avocado, potatoes, salmon, pomegranate seeds, etc. So, harmful effects of low potassium intake: hypokalemic diet. It has cardiovascular effect, neuromuscular effect, renal effect, and public health, which leads to public health implication. It is low potassium intake is a silent contributor to global hypertension epidemic. So, global burden of disease related to low potassium intake, it is linked to increased blood pressure, higher stroke and heart disease risk, and WHO identifies potassium intake as a key dietary protective factor. Adequate potassium intake can reduce stroke by 20 to 25% and lower blood pressure independent of sodium reduction. Another important concept is sodium potassium ratio. Health impact depends more on the sodium potassium ratio than either nutrient alone. Typical modern diets have high sodium level and low potassium level, which results in synergistic increase in hypertension and cardiovascular disease. Public health goal is to decrease sodium level and increase potassium level in our diets, which will have maximum cardiovascular benefit. In Pakistan, similarly, which I have explained below, that we have low fruit and vegetable intake nationwide, heavy reliance on cereal-based diet like pulses, etc., increasing processed food consumption, which is leading to higher hypertension prevalence, poor blood pressure control, elevated stroke and heart disease burden, low potassium intake, also excessive braid, sodium-related disease burden. Okay, so this is an interesting diagram which is showing the prevalence of hypertension in adult aged 30 to 79 years of age. So as you can see, in Pakistan the prevalence is of the dark blue color, which is about 40 to 45%, and in India it is low. India, the prevalence is about between 30 to 35% at population level, and we have prevalence of hypertension as 40 to 45%, which is very much high. Similarly, in few of the countries, the prevalence is even higher, with above 45% at all population level in adults. So the situation is very alarming at populations level, and specific measures should be taken immediately. Okay, so this is a paper which was published on 13th November 2025, and it titled is Potassium Enriched Salt for Patients with Hypertension, a Hypertension Australia and National Hypertension Task Force of Australia position statement. So what they did was basically that people who were eligible in this study, they were hypertensive. Instead of giving sodium chloride based salt diet, they were introduced to potassium enriched salt, and they saw that it had positive effects as a replacement tool for the normal salt. So their recommendation was that including this switch, additional dietary recommendation in clinical hypertension guidelines The wording was, if patients add salt to their food, they should make 1:1 switch from regular salt to potassium enriched salt with a composition of approximately 75% sodium chloride and 25% potassium chloride. Unless they are at risk of hyperkalemia because of kidney disease, use of a potassium supplement, use of a potassium sparing diuretic, or for another reason. Routine kidney health checks are recommended to support safe implementation of this. So now we will come to multiple choice questions portion of the MCQs. So we will start with the first MCQ. Which of the following best explains why calcium deficiency is considered a hidden public health burden? It presents with acute clinical symptoms, only affects elderly population, it accumulates silently across the life course, it is rare in low middle income countries, it is easily detected through routine screening.
C.
Yes, it
A.
accumulates. C is the answer. It accumulates silently across the life table. A district health officer in Pakistan reports that despite widespread antihypertensive use, blood pressure control remains poor at population level. Dietary assessment shows high intake of packaged snacks and low fruit and vegetable consumption. Which dietary intervention would provide the greatest population level cardiovascular benefit? Calcium supplementation for all adults. B. Reduction of dietary phosphorus intake. C. Simultaneous sodium reduction and potassium intake promotion. D. Iron and folate fortification. And E. Increased protein intake.
C.
Yes, so simultaneously sodium reduction and potassium intake should be promoted. WHO recommends calcium supplementation during pregnancy primarily to reduce the risk of gestational diabetes, preterm labor, postpartum hemorrhage, preeclampsia, neural tube defects.
D.
Yes, it is D, preeclampsia. A 22-year-old pregnant woman from a rural area consumes very little dairy and green vegetable. She presents at an antenatal clinic in her second trimester. The area has high prevalence of preeclampsia. According to WHO guide, which intervention is most appropriate? Advice, increase physical activity. B, start low dose aspirin only. Charlie, provide calcium supplementation during pregnancy. D, prescribe potassium supplements or increase dietary phosphorus intake.
D.
So provide calcium supplementation or make sure that the patient is um, taking increased supplementation during the pregnancy. Then, in populations with low dietary calcium intake, which mechanism primarily maintains fetal calcium supply during pregnancy? Increased maternal bone resorption, increased renal excretion of calcium, increased placental calcium synthesis, reduced maternal serum calcium level, or increased dietary phosphorus absorption.
A. D.
Yes. So it is mainly during lactation and pregnancy. It is due from increased maternal bone resorption. A nutritional survey show that adolescents often require frequently consume carbonated beverages and processed food, but rarely consume milk or fruits. Bone mineral density screening later shows suboptimal peak bone mass. Which mechanism best explains this finding? Excess potassium intake suppressing bone formation, high phosphorus intake combined with low calcium intake, low sodium intake impairing bone metabolism, vitamin C deficiency affecting collagen synthesis, or iron deficiency anemia reducing physical activity.
B. B.
Yes, it is high phosphorus intake from our diets and with low calcium intake. Which feature distinguishes phosphorus from calcium as a public health concern? Phosphorus deficiency is common globally. Excess phosphorus intake is more relevant than deficiency. Phosphorus has no role in bone health. Its intake is declining globally, or it is not regulated by kidneys.
B.
Yes, excess phosphorus intake is more of an issue than. We have high phosphorus intake is most strongly associated with increased morbidity in patients with hypertension, diabetes mellitus, chronic kidney disease, iron deficiency anemia, or chronic liver disease.
C.
Yes, it is C. And the last MCQ is a national NCD strategy proposes mandatory front of pack warning labels for food high in salt. The primary justification for this policy is that most sodium intake comes from salt added at the table. Sodium deficiency is common in the general population. Processed food contributes to the majority of population sodium intake. Sodium affects only individuals with diagnosed hypertension, or E, sodium reduction has minimal impact on stroke prevention.
C.
Yes, C is the right answer. This is the MCQ key. This is the YouTube channel where this video will be uploaded, and thank you very much for listening.
Thank you so much, Dr. Taimia. It was very